وان شاء الله تكون بدايه تعاون مثمر في مجال القلب وامراض القلب والدوره الدمويه. ونستغل الفرصه هذه، ممكن تاخذ 5 دقائق بس باش نوجهوا لهم اول حاجه كلمه شكر على حضورهم وتكبدهم معنا السفر والمشقه رغم الظروف ورغم الواحد الصعوبات اللي تجمع. حاجه ثانيه بقدم لهم شهاده شكر بسيطه جدا 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 من جمعيه القلب الليبيه، عباره عن درع بسيط تتولى الدكتوره حواء ان شاء الله تقديمه، وحنبدا ان شاء الله في الدرع الاول باذن الله. دكتوره الاستاذه الكبيره سنوات. شكرا لك دكتوره سناء على حضورك معنا وشرفتينا وانستينا، بارك الله فيك ان شاء الله. الدرع الثاني ان شاء الله بعون الله دكتور فرات السواري. دكتور فرات السواري واحد من الاجيال الشابه، بارك الله فيك على حضورك معنا وعلى دعمك. وطبعا فرات نعرفها باللينكد ان قبل ما نشوفها يعني، فشكرا لوجودك معنا في ليبيا، وان شاء الله نتلاقوا في ساعات ثانيه مباركه. الاستاذه الكبيره دكتوره ليليا زخام، شكرا لك على حضورك معنا ان شاء الله بعون الله، وان شاء الله نشوفكم في ليبيا مره واثنين وثلاثه وعشره ان شاء الله. احنا كان املنا ان اليوم في العشاء الختامي للمؤتمر تكونوا موجودين، لكن للاسف الطياره بتاعكم الساعه 7. ف بعون الله ان شاء الله الزملاء كلهم يكونوا في تونس. تونس قريبه نمشي حتى بالسياره مش مشكله. خلاص هذه نعتبرها دعوه رسميه من رئيس جمعيه القلب التونسيه لجميع الزملاء الموجودين في القاعه يمشوا تونس. نعطوه الدكتور محمد ولا الدكتور اسامه. طبعا كان واحد من الزملاء يكون معنا اللي هو الدكتور مالك بن مران، باسكولار سيرجن، بس ظروف العمليات والواحد اضطرات انه يقعد في مصراته، فهذه شهاده الدرع ان شاء الله ممكن تسلموها للزملاء في مصراته، سلموها لنا ان شاء الله بعون الله. شكرا لكم. So without any further ado ان شاء الله اليوم السيشن الثانيه في برنامج الدكتور سيرجي حتكون بخصوص الديفايسز and the problems related to device implantation and device management of patients. And it's my great pleasure to that Professor Sana Ouali will introduce the participants.
We move to the second session, and I invite Dr. Esam Baryun from the St. Mary Hospital from West Virginia. The talk is about prevention and management of implantable cardiac device infection, a great topic and a difficult situation. The floor is yours.
Assalamu alaikum. So prevention and management of cardiac device infection. First, 1 gram of cure is going to be better than a kilo of treatment. So prevention is really a main thing. Infection is not common. It's less than 2%, but the effects of infection is devastating. It can cost $146,000 for 1 incident. And the mortality is pretty high, above 60% untreated. If you give the patient max treatment with antibiotic and extraction, it's still 18%. And it's important to highlight that the primary implant risk of infection is a lot lower than if you go back into the pocket in the next few weeks or a few months. So revision always has 2 to 5-fold increase in infection. Infection increased not just because the number of implants increased, actually the infection rate increased and outpaced the the increase in implants. So why do we have more infections? Of course, our patients are older, more comorbidities. Our procedures are getting longer. A lot of times, the patient needs a gen change. You may have to add a lead. A broken wire could be extracted. You can upgrade to CRT. So the procedures are getting longer, and we're having more revisions. You can see on this side, you have the implants doubled, but the infection almost tripled. Microbiology, most of the infection will come from the skin flora. So you have staph, especially the coag-negative staph, the staph epidermidis, and then 1/3 is still methicillin-resistant staph aureus. And we still have 13% with no growth. The pathogen isolated from the pocket, a bit similar to the pre-axillary flora, most likely the patient is the source of infection. But if you have a disproportionate frequency of drug-resistant staph, that indicates that it came from the health environment. It's important to understand the biofilm formation. Some bacteria have the ability to form a biofilm around it that helps it adhere to the device and helps it protect itself from antibiotics. So the role of biofilm, it's a process where it forms extracellular polymers. And as you can see in the diagram, it protects itself and it ends up growing inside this protected biofilm. There are studies that are done now in vitro and in animals where they're studying the bioelectric therapy and biocaustic therapy to see if that could help reduce and increase the risk of the success rate of treating the infection with antibiotics. But still no studies. Overall infection, the bacteria can come from the package itself from the company. The patient can come to the hospital with bacteremia that's unknown, or it could be inoculated during the procedure. It can happen late from through the blood seeding, or it can happen late from a skin injury that leads to entrance of bacteria. Now, device-related issues, the device has metal. Some metals help or more hydrophobic, like the steel, stainless steel, the bacteria can adhere to it better. Less likely for titanium. When you look at plastic, same thing, the polyvinyl chloride will favor more adherence compared to Teflon. But of course, we don't really choose which, and then the size of the device, the larger, the more likely to get infected, and then the more irregularities in the device also can cause infection. So how do we prevent infection? This is a lot easier than treating it. So I think I want to focus on how to prevent infection. Patient selection is very important. Never rush to implant. The patient's in the hospital, he has a AV block. Hold your horses. Make sure the patient has no fever, no inflammation markers. Wait until the Foley catheter comes out, the central line comes out, the chest tube comes out. Don't rush to implant the device. Especially devices like that are not, mandatory or urgent. You can wait until the patient goes home and comes back as an outpatient. So patient selection is very important. Patient optimization, this also goes for people who have severe COPD or even CHF. They come in with CHF decompensation, ought to avoid CRT implant during that admission. Let them go home, get better, get optimized, and come back as an outpatient. So patient selection is very important. Prepare the OR. You want good ventilation. You want positive pressure ventilation in the room. You want filters to clear the air. You want good air exchange, but you do not want staph exchange. The staph who starts the case, preferably they should end the case. People going in and out is not a good idea. The door opening 10 times is not also helpful. Now, patient preparation, shaving the hair, only shave the hair in the area you're implanting. Shaving the whole chest is not good. The more you shave, the more you're at risk of nicking the skin and bacteria enters. If you shave, avoid razors, use electrical clippers. So electrical clippers are better than razor, and only shave the hair that you need to shave. Device selection, patients with hemodialysis, D-cube ulcers, amputations, and ischemic. But those patients try to avoid pacemakers and ICDs that have lead. You can do a subcutaneous ICD or a micro pacemaker if possible. Of course, micro is not going to help if you have sinus bradycardia. Micro is in the ventricle. It may sense the atrium 80% of the time, but it cannot pace the atrium. So sinus bradycardia, we're stuck with an have to put a lead pacemaker with leads. Reducing the hematoma, I can talk about that for an hour. I mean, hematoma, blood, we use blood cultures to culture bacteria in the lab. So blood will help the growth of bacteria. So you have hemostasis agents you can use in the pocket. You have pressure dressing after. And of course, reducing hematoma, Dr. Sana always focuses on this, don't bridge. That's the hematoma issue that we have. If you stop anticoagulation, give heparin, and then you do the procedure and then restart heparin, you're just increasing the risk of bleeding. It's better to do the procedure on anticoagulation if possible. If the patient has a low risk AFib, you can stop anticoagulation a few days before and then continue it 5 days after, and you'll be fine. But if the patient has a mechanical valve, then you could do the case on anticoagulation. Reduce lead complications. When you're implanting the lead, take your time. Extra 5 minutes during the implant is better than coming back next week to revise the lead. So antibiotic treatment regimen. The guideline, this study in Circulation of Physiology 2009, this set the stage for the IV antibiotic 60 minutes before skin incision. This is a randomized control study that proved that this is effective significantly in reducing infection. The PADIT trial challenged if we give more antibiotic. So they compared the conventional approach that had evidence to support in 2009 to an incremental antibiotic policy where we give more aggressively. We give 2 antibiotics before the procedure. We inject into the pocket the bacitracin, and there was no significant reduction in infection, but there was a trend towards reduction of infection. So you could use the PADIT trial strategy in patients who had high risk, but not in every patient. Interesting here, you can see the risk of infection. The pacemaker infection was the least, ICD higher, and then CRT the most. And you can see the pacemaker, the duration of the procedure is shorter, the hardware is smaller. So the more hardware, the longer the duration of the procedure, the more the infection. Rapid study used an antibiotic envelope that you can wrap the pacemaker or defibrillator generator with, and you can put it inside the pocket so it can instill antibiotic slowly over the next few weeks. And this also can reduce the risk of infection. The result was significant. It dropped from 1.2 to 0.7. So that is a good result. There was no complication from using the Tyrant sleeve, but the number needed to prevent one infection in a year was 200. So you have to implant 200 sleeves to save 1 patient. So it's really not worth it to do it on every patient. Then the good thing here is that the rapid study was done for high-risk cases, only gin changes, no new implants unless it's a CRT. So they did not include new pacemakers, new ICDs, only gin changes, upgrades, revisions. The only new implant was the CRT. And they proved that it helps, but then again, you need to use 200 sleeves, and those sleeves cost probably more than $1,000. So we use this for high-risk patients, immunocompromised patients, patients with kidney failure, diabetes, but not on every patient. So risk factors in general that put patients at higher risk of infection, male, comorbidities, age. In the past, we were saying old patients. Now there's conflicting data. Some studies show no, it's not older patients need more infection. Of course, medication like steroids and blood thinners. And again, number of leads, more than 2 leads, more risk of infection than 2 leads. Clinical features. Patient can present with a septic shock or just have non-specific clinical symptoms and signs. Unfortunately, still, the diagnosis is delayed. A lot of times patients will come with a secondary infection, like they'll come with an infected knee, but really the infected knee started from the pacemaker. It's difficult to tell. You may suspect that if it's a staph organism in the blood, but a lot of times it's difficult to tell. TE is negative, blood culture is negative, you're going to have to assume it's just a local infection. And if you have a localized infection in the pocket, most likely there's also a leaf infection. This slide will give you an idea that if you suspect that there's an infection in the pocket, if it's just an abscess around the stitch, you could treat it with antibiotics and clean it. Since it's a tiny stitch abscess, most likely superficial. If you think there is an infection, then you'll do blood cultures and TE. Now, a person may ask, why are you doing blood cultures if you already have pus here? You can culture the pocket and you can know what the pathogen is. That's true. But blood culture is important because it tells you whether you need to give antibiotics for 2 weeks versus 4 versus 6. So the blood culture result and the TEE result will help define how long the treatment's going to be. Then again, you have another approach if you already have if you're suspecting there's a systemic infection. So now it's not just local, the pocket's not infected, but you think there's a systemic infection affecting the leads. Same approach, blood culture, TEE. And you can tell the TEE, there's even a difference in treatment between the vegetation on the valve and the vegetation on the lead. So if you have vegetation on the upper lead here near the SPC versus on the valve, that could be different. Now, infections. Yeah, so infections in general, you can divide it into infective endocarditis affecting the heart, or just a lead infection, LI, or a generator pocket infection. So all you can see is just the swelling. I had a patient recently who had a swelling on a pacemaker that was implanted 6 years ago. He had a pacemaker, never followed with the doctor, and he comes in with a swelling. It was uncomfortable. On exam, I can't really say that I saw clear signs of infection, but the patient was saying it was not comfortable, no trauma recently. And at the end, we did a pocket evacuation, and to our surprise, it was pus. You can see skin tethering. Skin tethering could tell you that that could be a chronic infection, and that could be a sign of pre-erosion. You wait on that a few months, and you'll see the next picture. So what's the differential diagnosis of redness over the pocket? Of course, infection of the skin, subcutaneous tissue, the cellulitis. That's one possibility. Metal allergy, nickel, cobalt, even with, it's not just the jewelry, it could be ingestion too. Some patients can have metal allergy. People who have titanium allergy, I know Medtronic makes a pacemaker made of gold for those type of patients. I usually send them to an allergy specialist to test them to see if they have true titanium allergy. Now, irritant contact dermatitis. Irritant contact means there's no infection, and then it's not an allergy. It's just a skin injury that led to inflammation. So you can have a dermatitis, you can have an allergy, you can have an infection. Another type of viral infection, herpes zoster, or a hematoma, or malignancy. Don't forget malignancies. You can have a skin cancer there. You can have a patient who had breast cancer. Now the cancer is recurring in that area, and the skin looks inflamed, and it's really cancer. So you do not want to miss malignancy in patients who come. You know, this patient ends up having an extraction that wasn't needed. Sometimes biopsy would help resolve that issue. What's the differential diagnosis of a pocket swelling? Well, pocket swelling could be hematoma. It could happen, mostly it happens early, it could happen late. Hematomas, if they stay for a long time and they're small, they could sometimes break down into a material that looks like it's like pus or chyle, but it isn't. We call that a pseudochyle. Seroma happens after surgery. You know, you separate the fascia from the tissues over it, then with friction over time, fluid collects. Usually septi will form, and you can see that with ultrasound. Abscess, of course, should be ruled out. Tumor, lipoma has its special border feeling that surgeons know very well. Myeloma is not common, but patients who had a lot of radiation from cancer, they could have a fistula between thoracic duct and the pocket and form a myeloma. Or if the patient has a thoracic duct anomaly, while you were implanting the device, if you injure the thoracic duct, you could have a communication. And the way to define that is if you start first with exam. You look for signs of infection. You test the consistency. You see if it's attached to the underlying muscle or not. And of course, if there's a drainage, you press on the lower part of the pocket to see if there's a communication between the drainage side and the pocket. Ultrasound is very helpful. Endogenic versus anechogenic, solid versus fluid, are there septi indicating a seroma, or is there a vascular connection? Is there a connection between the fluid in the pocket and a vein or a thoracic duct? Labs, of course, looking for inflammation markers and infection. PET scan is very helpful to localize. If you have a swelling and you do not want to open the pocket, a PET scan can show that there's an infection in that area. The PET scan can also show whether the infection is on the upper part of the lead or the lower part of the lead. And of course, pocket evacuation could be a solution. This is a PET scan showing how it highlights the area of infection. You can see clearly over there that the infection is not in the heart, it's just the lead infection. And of course, they're using the FDG positron emission. And here, another area where the infection is between the first rib and the clavicle. This, of course, needs extraction. Vegetation size, the larger the vegetation, that's when we need our surgery colleagues. In the left side, 1 centimeter, right side, probably 2 centimeter. In the literature, some people will look at the area of the vegetation, 1.8 centimeter square. The larger the vegetation and the more mobile it is, the more likely is it to embolize. So those are the two things you want to look at: how big it is and how mobile it is. Consistency could be important too. If I extract with a large sheet and I feel that it's like a soft tissue that could be sucked into the extraction sheet, then I still probably would do the extraction. Another option for large vegetation for patients who cannot undergo surgery is a suction device. As an angiovac, you can introduce through the groin, and you can debulk the vegetation by suctioning it. Thank you.
Thank you very much, Victor. Thank you. We move to the second conference, the utility of SAIS to troubleshoot cardiac implantable devices that will be presented by Dr. Khalid Abozguia, Associate Professor Cardiology and Electrophysiology from Marshall University, West Virginia. Welcome.
Thank you.
Thank you very much for the introduction. Okay, so today I know there is a wide spectrum of level of experience in the audience. So I know the audience will have experience with other devices. I'm going to start simple and then go up in complexity. We'll try to cover some troubleshooting when you enter the chest X-ray. So we always start by trying to identify the factor of the device, identify the type of the device, and then troubleshoot the X-ray if you have a problem. So why it's important to know what the manufacturer? Unfortunately, yet we don't have a universal machine which can interrogate all devices. So as you know, that there is at least 4 major companies. So you have to pick the right sheet to integrate the device. I know from speaking to colleagues in Libya, mainly they implant Abbott or Troubleshoot, maybe a few Medtronic, but less Bitronic and Boston. We as electrophysiologists looking at X-ray, we developed the experience to know most of these by experience. But if you don't have the experience, there is actually an app. You can find it in iPhone and Android. It's really free. You look at the X-ray, you snap the picture, and it tells you what manufacturer it is. Most of our fellows find it really useful. So I would recommend you download it, and it's free. Okay, now we're going to move on to short cases and see if we could try to differentiate between the different types of pacemakers. This is just a standard to start the X-rays. You could see 2 leads, one like it's in the right atrium, another one is in the right ventricle. So this is likely to be what we call a dual chamber pacemaker. So this is just to show you that standard pacemaker, it can be dual chamber, one in the right atrium, one in the ventricle. Sometimes we can have only single lead. Usually we put it in the ventricle. But, and this is just to show you that sometimes we put them in the left side, the generator, sometimes in the right side. We prefer the left side because the course of the lead is better. However, if the patient is left-handed and they don't want any restriction to their left hand, sometimes we put them in the right side. And this is just to show you 2 examples of dual chamber pacemaker on the left and single chamber ventricular lead on the right. Not all single chamber are ventricular. We discussed this, I think, last in the pacemaker workshop. We sometimes, not very commonly, we put just single chamber in the atrium. We call it AI. And you could see there is only 1 lead in the atrium. Always remember to look at the X-ray. Everything in the right side should be more anterior toward the sternum. Anything in the left side should be more toward the spine. That way. Okay, now we move on to different type of devices. Hopefully, after looking at these X-rays, we can tell the difference between pacemaker and ICD. This is the dual chamber ICD. Why this is an ICD? If you see the ventricular lead, there is part of that lead looks very thick. We call it the coil. Sometimes you have 2 coils, one where you see it here in the right ventricle. Sometimes you see another one in the SVC region, so we call it dual coil. But this one is dual chamber ICD, single coil ICD. You could only see 1 coil in the right ventricle. And this is how we differentiate between pacemaker and ICD from X-ray. Now, this is a different type of device, and I took 2 pictures of the sides. And the image on the left, what we used to implant long time ago. The image on the right, this one here is what we tend to implant. So this is a BIV, so there is an extra wire, not just in the right atrium and the right ventricle. We also put a lead in the left ventricle. I always, when I was a trainee, I always think, how do I get to the left ventricle going from the venous system? Should we not be going through the aorta or femoral artery, but we go through the coronary sinus and then we select a branch from the coronary sinus. So actually the lead is not inside the left ventricle, it's outside, it's epicardial. It's in the epicardial branch from the coronary sinus. The image on the left, you could see there is a wire which has only 2 poles. Whereas nowadays, if you see the lead, the LB lead has 4 poles. So you have more options. And the reason why we like it is because when we place the lead, sometimes we have issue with pressure, sometimes we have issue with stimulating the phrenic nerve. And when you have only 2 poles, you're limited. That's it. So when you have 4 poles like that, you have 16 or 17 pacing options you could choose from to achieve the best pressure and avoiding phrenic nerve stimulation. So now we routinely, I would say, we use the multipolar LB. And this just to highlight why I say that the way we pace the left ventricle, we pace it from one of the branches in the coronary sinus. We prepare the lateral region, preferably posterolateral or anterolateral. We don't want to go anterior because you're essentially facing closer to the right ventricle, so we don't want that. Okay, so we move into more new technology. This is something I'm not sure it's available in Libya yet, but something this we use commonly now for specific group of patients. We call it leadless pacemaker. So there is no generator, there is no wire. It's a small capsule. If you compare it to like a coin, and we deploy it from the blood. So this is something we use for a specific group of patients where we think putting the generator or lead as risk, for example, infection or vascular issue. You have maybe a dialysis patient, one port on one side, the other side is blocked. So you're limited where you access the heart from the top. So this is an option. Or someone commonly used for patients who develop recurrent infection from pocket. So this is an option. We call it leadless pacemaker. Commonly one used is for Medtronic, but others are coming with a revised version of their own leadless pacemaker. Now, it's very important to differentiate an X-ray between leadless pacemaker and a loop recorder. They may look the same on X-ray. But if you look carefully and you look at the lateral chest X-ray, the loop tends to be in the anterior wall. It's not inside the heart, whereas the micro should be inside the heart. So the lateral view, you can see very clearly, it's not actually in the heart, it's in the wall. But you could tell from the shape of the device. But you're really struggling and you want to see, oh, is this a loop or a leadless pacemaker? The lateral chest X-ray is very helpful. Okay, now this is another type of device, again, specific indication. You could notice on the image on the left there is what looks like a coil and a generator by the side of the patient. And the lateral chest X-ray clearly shows that the generator is actually almost on this area here in the axilla. And there is a wire which looks thin, and then there is a part of it looks thick, almost like a coil. And this is what we call subcutaneous ICD. So this is an ICD where we don't implant it inside the heart, we implant it just under the skin and the chest wall, and we have the defibrillator wire. This can only shock, deliver a shock. It's limited in terms of pacing. So it has limitation. The advantage of this device is if you have issue with infection, vascular access, it's a good option for patients who want to avoid risk of leads inside the heart or pocket infection or anything. So this is another thing that we commonly use for maybe younger patients with high risk of sudden cardiac death, but they don't need pacing, or some patients with vascular issues, or some patients with recurrent infection and endocarditis with intravascular devices. Right. Now, this is another device. You're probably thinking, what's going on here? This is just too much. I'll give you another one. This is the lateral view. You're probably thinking this is a suicide bomber or something, but it's actually a live vest. So this is something we use as a bridge for someone who needs a defibrillator until we decide whether the patient needs an ICD or not, whether we're waiting for infection to clear or we're waiting for the LV function to see if it improves with medication or not. So this is something we use now and again to protect the patient while we're waiting to make a decision. So you may see an X-ray look like that and you're thinking, what's on? Right, so this hopefully covers most of the devices, and hopefully after this session, you'll be able to differentiate between what a pacemaker looks like, what a dual chamber, single chamber, what an ICD looks like, leadless pacemaker, subcutaneous. Now we come to troubleshooting. My way of troubleshooting X-ray, I always start from the generator. Look at the generator, look at the connection, make sure the connections are well connected. Then start following the lead. How many leads are there? See if there is any fraction, any kink. Then make sure the lead is in good position. After that, I go to the surrounding structure, look at the lung, look at both sides. You'll be surprised there is a report of pneumothorax on the other side. So look at that, making sure there is no pneumothorax, hemopneumothorax. And always remember, your best friend is the lateral chest X-ray. Having only peer review will not tell you the whole story. I think the obvious thing here is there is a fracture at the top. I don't know if you notice, but there is a lead fracture. Now, this is another common complication, what we call a Feautures syndrome. It's clearly the patient was put in their device, and you can see both the atrial lead and ICD lead retracted, and obviously the lead is blue. And this is another good indication for leadless pacemaker because they cannot do anything. If you put the device again, very likely it will happen again. They cannot stop doing it. So this is actually very useful to have the leadless pacemaker. You put the leadless pacemaker or the subcutaneous ICD because it's a huge, they cannot do anything about it. So Okay, we go to the next one. This is different type. I won't bother you with this. It all fall under the Twiddler syndrome, but there is different type. Okay, so this is a real case. I was a fellow when I was in training. I was asked to discharge this patient. Typical standard indication, standard procedure, do a chamber pacemaker. Patient doing absolutely fine. Here, okay, now, okay, sorry. So typical indication for pacemaker, patient doing fine, the bus check is okay. This is a chest X-ray. Then I always ask for lateral chest X-ray. When you look at this X-ray, it looks okay, but when I looked at the lateral X-ray, I was very worried. I started panicking. My heart rate started going up. Because if you look at that ventricular lead, you could see it's pointing posteriorly. Remember I say everything, the right ventricle should be anterior, close to the sternum, not to the spine. And the lead is in the posterior part of the, so I'm worried. Why? Because I think the lead could be, or so how can it go to the left ventricle? Either go through a PFO, through an AS lead, or sometimes it can go through the coronary sinus. So there's different options. But I was mainly worried about whether it's gone through a PFO to the left ventricle. So this is just an illustration of what the chest X-ray look like, and you expect all the lead to be pointed anteriorly, unless you have an LV lead, then you expect it to be posterior. So I quickly did the echo, confirmed that the lead was actually in the left ventricle. We start panicking. We listed the patient for revision extraction with surgical backup. Question is the heparin was an issue, but ended up with hematoma, but then that's settled. So lateral chest X-ray is your friend. AP can only tell you are atrial or ventricular. To know if you are right or left, you need to do a lateral chest X-ray. Another tip, if you work with an implanter who doesn't use LAO during implant, we have a problem. You have to use LAO. If you don't use LAO view, you don't know if you're on the left side or right. Okay, so clearly our case, the LB. Okay, final two. Please, this is just access issue. They are looking. I was pregnant. And this is the X-ray, what it looked like, and this is obviously something you don't see very often. Left persistent SVC. It's really tricky, especially to position the ventricular lead. This is another true case again about to discharge the patient. The patient here wasn't well. She was very concerned. When I looked at the X-ray, the ventricular to me looks very. I was suspicious. She was complaining of chest pain.
So Khalid, still you have 5 minutes. Sorry for
5 minutes.
5 minutes. Go.
Okay. I'll slow down. Can you still hear me okay at the back? Okay, good. So this patient, unlike the first patient described, she was very unwell. She was complaining of chest pain. She just didn't look well. And I looked at the first thing struck me that ventricular lead. Remember, the border of the heart is usually made in the left ventricle, right? And here the lead looks like it's so out. I was concerned there is perforation. I looked at the lateral X-ray. It does look like it's pointing anterior, so I'm not suspecting it's in the left ventricle. I was worried about perforation. I did a quick echo. I couldn't see any obvious pericardial effusion. I decided I'm going to organize a CT. There was a delay. What do you think I did next? No, I will never do that. Oh, no. Yeah. Last result. Irrigation, absolutely fine. Patient still not very well. Doctor, I'm having chest pain. Blood pressure start to drop. So Dr. Baryun suggested fluoroscopy. So I was a fellow then, and I was in the weekend. And this is something I missed, and I think everyone will miss. I was mainly worried about perforation. But look at the lateral chest X-ray. Yes, what do you think of? I'll point this because this is really important. Okay, now guess what happened? And this is really a good message from this case. I repeated the chest X-ray because the CT, there was a delay.
And what this message tells me is, doing early chest X-ray, you could miss pneumothorax. The recommendation is, if the patient is stable enough, you should not repeat the X-ray before 3 hours of implant, because you may not see an early pneumothorax. So I struggled with the CT, there was a delay. I repeat, because the echo was fine, I didn't see any effusion. So repeated X-ray, it was clearly pneumothorax. But looking back at the lateral X-ray, there was clearly evidence of pneumothorax there. Good, right. Let's just, this is more fun when it's interactive. What is the abnormality here? Any volunteer? This will be more fun if it's interactive. I've showed you the lateral X-ray for a reason, because if I show you the PA view, it will be too obvious. Atrial lead, the Dr. Manawar is allowed. So I don't know if you see it top there, the atrial lead is displayed. And if I show you that, you could see in the PA view, the atrial lead is displayed. Okay, right. Let's show you another view. If someone knows this, I'll be very impressed. Got 2 minutes, we are good in timing. So this was, I was a fellow, I know nothing about the patient. I was about to do a flutter ablation in someone with an ICD. And then this is what the X-ray looked like. And I was like, oh my God, what's going on there? Any idea? Anyone can answer this. Sorry? Sponge. Dislodge. So sorry, I mentioned that I'm doing a flutter ablation here. So there is a old ventricle lead, there is a new ICD lead, there is a couple of catheters. But what I was really referring to, what these patches look like. See these, what I call number C and number B. There is, I don't know if you see these except cable going down, these two patches. So this was apparently one of the first patients in the UK having epicardial defibrillator leads, surgical. Thank God we don't do it surgical anymore. So I've never seen one. Hopefully you guys will never see one either. So, okay, this is really practical, very common. This can happen. This is practice. I always, when I finish implanting a device, I always do a final X-ray and zoom. What connection do you think you are happy with? So I think I'm worried. Image, which one you'll be happy with? Image A, image B. Volunteers. You'll be happy with. So we have A, B, we have 50%. Okay. If I am, which one did you say? Okay. So image B is good. I think I don't know if you see A, the bottom one, you don't see the connection. You see the top two, you can see the pin coming up. But the bottom one, the pin is not up. So there is a connection issue. We repeated it, and I think the other view looks like all the pins are okay. So it's really crucial, not just you connect the lead and click it and check it. You always have to check with fluoroscopy that it's well connected. Right. I think this is, I'm pretty sure this is our final case. This is, it's, especially when you do extraction, Dr. Baryun will tell you, you hate to be in this position. There are so many wires, you don't know what's going on here. So I'm only asking you what is wire A is. Any idea? So this is an extra coil in ascites. So sometimes you have issue with the defibrillator. You have to put an extra coil to improve your defibrillation threshold. And you know it's in ascites because it's posterior and it's only a coil. This is, I think, sorry, this is the final one. This is why I mentioned that when you implant, you have to do LAO views. And the reason why, what is the issue here? No, I think this was probably passively. This is very old device. This is LAO view. Remember LAO view, to the left is your left side. Middle is septum. The right is the right free wall. So where is the ventricular lead is? It's in the right free wall, right? So this is very high risk of perforation. You want it to be more septal toward the middle. from LAO. You want it to be pointing toward the left, but not too left-sided. See, this is why when you implant, you have to make sure you check the LAO. And I think I was told that it's time, and we finish in time.
Thank you, Dr. Khalid, for this amazing and funny cases. Thank you. And we move actually to with Dr. Yousuf Darrat for when to implant BB devices in heart failure patients. Dr. Yousuf Darrat from San Jose Hospital. From United States, Kentucky, United States.
واضح تمام. خالد كملت البطارية يا خالد. صرنا وينك؟ نتكلم على ال BioFilm implants يعني BioFilm ICD أو BioFilm Pacemaker. So the objective selecting cardiomyopathy patient for BioFilm pacing. So which patient we can use BioFilm pacing for, understanding the importance of BioFilm pacing for complete heart block, and understanding the ideal location of the coronary sinus lead. Dr. Khalid already explained some of my work. It's good to help me. So what's BioFilm pacing or re-synchronization therapy? The left bundle branch block هيكون في the left ventricle beats after the right ventricle. نتيجة the left bundle. نتيجة the delay in the conduction system and the delay of the impulse getting to the left side of the heart هيكون في desynchrony. يعني هيكون في delay in getting the electrical impulse towards the lateral wall, which could be associated with mitral regurgitation, reduced cardiac output. So that's when the role of a B can be considered. So I tell when we implant the BioFilm, we want the right side of the heart to talk to the left. Your left ventricle doesn't know what the right ventricle is doing. That's really the simplest way of describing it. But it could be associated with mitral regurgitation, reduced cardiac output, and stroke volume. فالليفت bundle branch block شنو هو left bundle typical left bundle branch block definition هيكون QRS QS or RS complex in V1 والبيفid complex في V1 أو V6 اللي هو النوتش أو in V6 and M shape في V6 أو lead 1. So هنديروا it's a case based presentation. But the first case 75-year-old female with ischemic cardiomyopathy. Ejection fraction 20%, NYHA class 2, اللي هي 20%, severe MR, patient عندها severe MR. But she's on maximum with guideline medical therapy, metoprolol, XL, and Presto, who cannot maximize further because of blood pressure issue. فشو رايكم, is this left bundle or not a left bundle branch block? Yes or no? قلنا احنا البيفد اللي هو الام شيب البوينتر يشتغل الليزر بوينتر تمام يشتغل لكن مش غش فلما تشوف مثلا ليد 1 واضح اللي هو ام شيب وعندك الكيو اس الانترسكويد ديفلكشن شورت انترسكويد ديفلكشن فديس از تيبيكال ليفت باندل برانش بلوك الويدث بتاعها definitely about 150 maybe or definitely more than 150 like magic number هو 150 for success يعني to ensure success of BioFilm based نتكلم عليه بعدين. For next best step, ICD, BioFilm, ICD, or microclip عند severe MR. And someone could argue, well, let's do a microclip. The surgeon could say, well, let's suction the heart, let's fix the valve, and then think about a BioFilm. Oh, what would you be? Or none of the above. None of the above. by VICD. I would go by micro-regurgitation. Why did we put that? Regurgitation based on the echo secondary. It's functional. نتيجة الدايليتيشن بتاع المايكرو annulus هتصير regurgitation. If you fix ejection fraction, improve ejection fraction, there's a chance that the micro-regurgitation itself will improve. Okay, هذه real life case يعني هذه الحالة اللي F 20% هي MR هذا before وبعد الامبلانت طبعا we would like to see an RS complex يعني يكون زي الرايت بندلش D1 عادة we prefer negative in D1 بس يكون positive with superior access. اللي F improved after like 3 to 6 months from 20% up to 44% والMR definitely improved significantly improved. دخلنا الأسئلة بعدين بسرعة أفضل. أنت أول واحدة بس okay. فimproved the F from 20 to 44 وحتى المايكروجيتيشن improved. Should studies that support BIB pacing. One of the first studies is the Implant trial, which is the first randomized single-blind trial for CRT for congestive heart failure. شبكوا للfunctional status. They showed a significant improvement in functional status, greater distance walk with 6 minutes, or fewer hospitalization. The medical trial was another trial that showed actually hospitalization and death. Okay, multiple studies. Companion trial كانت أكبر واحدة 15,000 مريض EF less than 35%. The selection criteria كان QRS more than 120 included in that study. NYHA class 3 or 4. Class 3 طبعا with mild exertion, class 4 at risk ambulatory congestive heart failure symptoms. There was definitely a reduction in all-cause death, a reduction in heart failure death. But this showed a mortality benefit with BIB. It's not just functional improving functional status or improving ejection fraction, also reduces mortality. هذه very busy slide بس اللي بنحاول يعني بس البوينت ما اشتغلش بس اللي بنحاول إن نوريكم إن the best improvement is actually the wider the QRS complex, the better the chance. عادة the cutoff is of more than 150. Though more than 150 milliseconds, and left bundle more than 150 milliseconds. Okay. Females usually they respond better than males. Those are the important ones. Okay. So next slide. MEDIT CRT was another trial. It also included class 1 patients, ischemic cardiomyopathy class 1. Class 1 and 2 or non-ischemic class 2, EF less than 30%, QRS more than 130 milliseconds. وsinus rhythm طبعا والAFib is going to be a problem because patients with AFib they interfere with the BIB functionality. They randomize ICD versus CRTD. يعني you're comparing device to device, not just the medical therapy based on previous trials. It definitely showed that probability of survival was higher in CRTD or BIB ICD patients compared to only just ICD. But definitely in a well-selected patient BIB ICD is better. يعني لو patient عندك left bundle branch block in an NYHA class 4, ischemic cardiomyopathy 1, 2, or 3, or even 4, BIB is better than ICD. طبعا ICD implantation for class 4 is a contraindication. You don't get ICD, just an ICD for class 4. Like if you're planning a BIB, you can justify the ICD. Okay. Improvement, not just functional status, it's not just mortality, حتى improve the ejection fraction, improve the anti-stolic, حتى هيكون في positive remodeling. The ventricle would positively remodel. طبعا لو تلاحظوا هذه important slide, the benefit was really seen in patients with left bundle branch block. يعني non-left bundle, right bundle, IVCD, the left bundle was better with regards to heart failure, death, VT, VF. يعني left bundle branch block هذه class 1 indication per guideline. So data from MEDIT CRT conclusion heart failure patient on class 1 or 2 is expression 30% compared to ICD. There's definitely benefit of CRTD, reduction heart failure progression, reduction even in ventricular tachyarrhythmias. No evidence CRT was observed in patient with non-left bundle, whether it's right bundle or IVC, regardless of their QRS duration. And we sometimes do implanted for patients with right bundle, maybe severe and wide, maybe more IVCD because the referring doctors, and I've tried everything, patient keeps being admitted. I try to avoid an intraventricular conduction delay. In left bundle branch block, definitely there's benefit. Left bundle branch block QRS had the guidelines and in the European guidelines, which is very similar to the American guidelines. And then they agree left bundle more than 150. Busy slide and summarize left bundle more than 150 milliseconds. Class 1 sinus rhythm candidate for a BIV. الكيس الثاني 87-year-old man with complete heart block. كون shift gears الجزء الاول وانتم كلكم تعرفوا هو ischemic or non-ischemic cardiomyopathy left bundle more than 150 في indication BIV ICD. فالبيشنتس اللي عندهم complete heart block مثلا they have frequent pacing. We know that frequent pacing induces left bundle يعني it's like a artificial left bundle. هل المرضى ما يصير لهم نفس الحاجه؟ yes. نفس الشيء ممكن يصير. There's something called pacemaker induced cardiomyopathy. The pacemaker with frequent pacing, the ejection fraction will drop. فالمريض هذا عمره 87 سنه complete heart block كان عنده pacemaker في 2019 implanted for sinus node dysfunction لكن بالوقت he developed complete heart block significant and more pacing. The ejection fraction dropped from 55% dropped to 15%. ولما ديت الانترجيشن his pacing was 100%. وانا لاحظت ان البيسنج became more frequent in the last 6 months. فقلت احتمال تكون هذه pacemaker induced cardiomyopathy. طبعا he's 87. I think he has cystic cardiomyopathy. I told my interventional colleague to do a heart cath, make sure there's no ischemia. Heart cath was okay, didn't show anything significant. Okay, فالpatient قلت I added an LV lead. We added an LV lead, not an ICD, didn't do an ICD. He's 87, and I know it's most likely pacemaker induced cardiomyopathy. So just with implanting the BIV, his symptoms really improved. Well, this is what I would like to see. I would like to see a right bundle morphology B1 with negative and lead 1. زي ما قال دكتور خالد, we like to face from the lateral side. حتى السيرجن لما يحط epicardial wires, if we can't put the endocardial, we wanted to put it laterally. Then هذا المكان in the left bundle, that's the last place where the electrical impulse gets to. But the latest site of activation. فهذه leads C1 معناها you're facing from the lateral aspect of the LV. The patient symptoms really improved, يعني functional class really improved. ما زال بدأ flash echo to see if there's any improvement طبعا. طبعا قصة إن pacemaker induced cardiomyopathy was recognized over the years. David trial is one of the landmark trials اللي شافوا فيها إن more pacing worse. يعني لما you pace more the RV pacing, there's worse outcomes. هذه study كانت فيها ICD pacing DDI versus DDR pacing. واكتشفوا البيشنت اللي هم DDR pacing يعني حطوا DDI 40 versus pacing I think at 70 ما بتذكرش بالضبط 70. اكتشفوا the patient with more frequent pacing worse outcomes, more congestive heart failure and actually more I think there's also more chance of that 1.6 hazard ratio. Another one was most trial, which is a study of it. لاحظوا إن if you pace 40% or more, you increase risk of congestive RV pacing. RV pacing 40% or more, there's 3 times increased risk of congestive heart failure hospitalization. وفي study حتى توا موجودة يعني هو even 20%. Some studies showed even 20% there's more adverse outcome, which is this one. Incidence of predictors of RV pacing induced cardiomyopathy patients with AV block and preserve ventricular solid function. And at baseline, they had a normal EF. Definitely, RV pacing more than 20% is associated with a more decline ejection fraction. اللي عندك الاكسس اللي هو freedom of left ejection fraction decline, the RV pacing هيكون worse compared to less than 20%. البريدكتورز هيكون اللي هو lower baseline ejection fraction. يعني لو المسج ان البيشنت لو جاك في low EF borderline low EF يعني مثلا patient ejection fraction 45% وجاك complete heart block, I would recommend the BIV من أول. Put a BIV from day 1. لو ejection fraction is normal, really there's nothing to support in a top BIV. I would put a dual chamber pacemaker. وبعدين لو ejection fraction drops, we would add the LBBB. We know that pre-existing low EF is a predictor for worsening EF if you have frequent RV pacing. The other one is the pacing more than 20%, 6 times, hazard ratio 6 times. So there's 6 times more chance of developing low EF. Okay. Those and male, I don't know really why, but males are more likely to develop that. The pacemaker induced cardiomyopathy. Had the block HF. Block HF is one of the landmark studies published 2013. It was one of the studies that showed that about any patients, it's Medtronic sponsor study. They most of the patients have ICDs. EF was around 35%. They randomized them to valve pacing versus just dual chamber ICD. A lot of the patients were in complete heart block. Okay, most of the patients have complete heart block or frequent pacing, which complete heart block was complete heart block, second degree, and also long first degree, more than 250 milliseconds or 300 300 milliseconds. But frequent pacing, الفكرة فيها frequent pacing, more chance of lower EF or worsening ejection fraction, especially in pre-existing low EF. This study showed that body pacing is better than right ventricular pacing. Had the study, I don't think it was published, had the Abbott or St. Jude BioPace study. They included patients with normal ejection fraction. Most of the patients had normal ejection fraction. They didn't show that it panned out. It was not clinically statistically significant. لكن بتشوفوا it's kind of opens up at the end. يعني body pacing was slightly better than RV pacing, and this is in patient with normally at 55%. فاللي سوى يعني there's no strong data to say if someone has a normal ejection fraction at baseline to put a BIV. فهذه goes against putting a BIV in a normal EF. حتى respectively to RV pacing. Case 3, 47-year-old presents with complete heart block, EF 30%, no history of CID, had history of hypertension. Okay, shouldn't write them. So patient J, the complete heart block, young guy, he's marathon runner, يدير في marathons يعني يجري. فجأة ما لبيد عليه فجأة خش في complete heart block يعني ejection fraction dropped. So what would you do? شو ال EKG يوضح? What does the EKG show? شو ال EKG? Okay. نعم. left bundle ما شو في ثاني غير left bundle. complete heart block. complete heart block يعني شيء AV dissociation. P wave AV dissociation complete heart block. Okay. فطبعا ده heart cath, there's no coronary artery disease. شو الخطوه الجايه؟ EP study for the monitor, cardiac MRI, none of the above. cardiac MRI to look for infiltrative disease. يعني ممكن يكون عنده sarcoidosis بعد. وفعلا هو الMRI ده وبين عنده sarcoidosis يعني suggestive sarcoidosis based on the LGE distribution, it's likely sarcoidosis. So what's your next step? Buy the pacemaker, buy the ICD, or do ICD. Buy the ICD. But ejection fraction can مثلا نقولوا 50% or 45%. ICD. عشان sarcoidosis, you have a lower threshold development. Those patients are at risk of arrhythmias. The sarcoidosis, the FIT sarcoidosis, higher risk of arrhythmias. يعني ventricular arrhythmias. Indentation of fibrosis. Okay, so yeah, and his ejection fraction 30%. He meets indication, but you don't have to optimize medical therapy. He needs an ICD. Okay, ICD. This is his EKG. طبعا he has frequently للأسف يعني I saw him in follow-up. This is how it should look like. Right bundle branch block, or right bundle morphology because of RV pacing. Negative in lead 1 or 2. Negative in lead. Okay, looks better. Yeah, he looks. His ejection fraction was about 40% of follow-up, but he has frequent DVCs. هذه كانت المشكلة احنا واقعين فيها يعني. I'm going to try to treat him with antiarrhythmics or optimize medical therapy. Ablation is an option to get rid of the PVCs. Okay, so guidelines management for patient with bradycardia or conduction disease. In patients, somehow including guidelines in patients with AV block who have an indication for pacing. This is the European guidelines, by the way. EF between 36 and 50% are expected to require RV pacing more than 40%, or حتى 20% of the time. And I data. It's reasonable to choose a cardiac resuscitation therapy. Or HIS bundle pacing. Okay. هذه الامريكان I think this is the American or this is the actually this is the American, this is the European guideline. Same thing, you have less than 30%, 40% AV block 5 يعني physiological base, يسموها physiological base. وين نحط ال LB دكتور خالد already kind of talked about it. Don't put it in anterior interventricular vein. We want it lateral, anterior lateral أو posterior lateral. نحط لنا anterior lateral. لأن anterior interventricular branch حيمشي على الجنب right ventricle. We want it further away. Okay, so we engage the coronary sinus, we put the lead, we select one of those branches in the lateral wall. Okay, هذه ال optimal bivalve pacing QR lead 1 with negative or R S ratio more than 1 and V1. Okay, optimal bivalve pacing. New approach, left bundle branch pacing. It was an idea in China in 2014 في مجموعة دكتور دارات في الصين ان the idea is that his bundle pacing لما نحط lead في his location to capture the his to allow physiological pacing has limitations. Then I feel there's complete dislodgement, really selecting a good position. ففي ما انتشتش بصورة كبيرة. فالدكتور كان فكرة نحط lead في left ventricle في right ventricle على septum and you really twist it to engage the left bundle. So you pace on the left bundle. So more to engage the Purkinje system, you have better physiological pacing. هذه left bundle 165 هذه left bundle branch block وهذا بعد الpacing. شوف الكيورس complex is really nice. It's almost normal because you're using the patient's own Purkinje system rather than putting an LBD. Okay. So I just wanted to make sure you're aware of left bundle. شكرا.
If the question in the audience.
شكرا دكتور يوسف. اذا كان في اسئله ممكن توجهوا للكانديديتس ولا الدكاتره اللي المايك انا موجود في الواحد. يعني نطلب من السبيكرز انهم يجوا على الستيج to join us on the stage to answer the questions of the audience. Thank you.
Assalamu alaikum. MashaAllah, well done. Excellent presentations. Just a question, Dr. Yousuf, on the CRT. I think guidelines CRT, start with CRT-D or CRT pacemaker for ejection fraction less than 50, because we know 35% for sure CRT-D, but more than that you can choose based on certain criteria.
Ejection fraction is not 35% or less. It's a 5V pacemaker, 5V pacemaker, مش ICD. يعني حط RV lead without a coil و lead في coronary sinus for 5V pacing. Hopefully, inshallah, مستقبل 5V pacing might be replaced by left bundle branch pacing. Because حتى the 5V pacing is challenging. You have to find a good location, you have to get the lead. So hopefully, inshallah, مستقبل left bundle branch pacing would be the future.
Thank you for the presentation. هي كانت بس استفسار هي البايف اي سي دي هو نفس المصطلح بتاع السي ار تي دي وشنو الفرق بين البايف اي سي دي والسي ار تي كديفايس؟ السكند كويشن excuse me اذا كان ال بي دي ومعها اي اف هل في decreasing the mortality the same result improvement as LBB while the TRS only reduce injection fraction ولا لا؟ Thank you.
بالنسبه للباي في equals CRT يعني cardiac resuscitation therapy هي نفس الباي في بس هم زي مصطلحين يعني نفس الحاجه انا كتب you facing both ventricles باي في facing the right ventricle the pacemaker wire العادي والleft ventricle the coronary sinus. You can't put the lead في left ventricle that's going to cause thrombosis. So we select the coronary sinus to pace the left ventricle. ده نفس الشيء. لكن في pacemaker هو مجرد pacing only وفي الاي سي دي فهذا اللي هي يختلف سي ار تي بي هو pacemaker او سي ار تي دي هو defibrillation. والسؤال الثاني الايفب مشكله الايفب طبعا في الجايد لاينز لما تشوف تدريها تدري sinus rhythm left bundle more than 150 it's a class 1. لما تبقى في ايفب بيحطوا فيها class 2 ولا class 2. لأن الAFib itself interferes with biofilm. That's when the role of PPI, AFib ablation, has a role, or AV nodal ablation in certain patients. Yeah. Then الAFib نفسها an outcome is not as great as side with my biofilms.
Want to add one more. It's really important before you consider putting a IV, you do everything to reverse any reversible causes. And AFib and tachyarrhythmia is a common cause of LV impairment. So you have to make, if you think it's suitable, you have to go for a rhythm strategy, optimize medical therapy, reassess the LV before you consider IV. Absolutely.
I want to mention a few points about the pneumothorax after device implant. Like one of the speakers mentioned, you don't do like a quick chest X-ray, you might prefer the next morning because some pneumothorax takes a while to develop. Like Khalid mentioned a good point where the device was implanted on the left side and patients could develop pneumothorax on the right side. And the reason that happens is, for example, if you're putting an atrial lead in a patient with emphysema, you can easily poke the right lung with your atrial lead, and that's why we avoid putting the atrial lead lateral in patients with emphysema, because you can easily cut the pneumothorax on the right side, even though you're implanting on the left. So pneumothorax during device implant is not just from venous access; it can happen from atrial lead puncturing the lung, and rarely, just for exams or just to know. I mean, some people have what they call a buffalo flora, where both lungs are communicating. So you can cause pneumothorax here, and the air can develop on both sides. So because of the time, we have three more questions in the one semester. So جماعة بعد ممكن تمشي للمايك هذه لأن الشباب ممكن معلش عفوا.
السؤال من الدكتور عصام. We know one of patient categories for the life of our device fixation, renal patient with IV fistula. Is there any role for repairing patient removing IV fistula, especially in patients with recurrent fixation of device or pocket infection?
Yeah, if the patient has an AV fistula in one arm, you're going to implant on the other side. I prefer to do leadless pacemaker if possible, like a micro, or if they need an ICD, a subcutaneous ICD. But if the patient needs the device, you don't implant on the same side where the fistula is. So, for example, if the patient has a fistula on his left arm, you can implant on the right side. If the patient has a fistula on the right, you can implant on the left. Did I answer your question? So yeah, there is a high risk of infection, unfortunately, and that's why you're going to have to use the pilot sleeve and give more aggressive pre and post antibiotic regimen.
So, you have someone with, let's say, stage 4, يعني almost close to dialysis, okay, or someone who hasn't had a fistula yet. عادة جماعة الفروجكس they put fistula on non-dominant arm, left side. But لما نشوف مريض و he's almost end stage renal disease, I try to implant a pacemaker on the other side to avoid يعني حتى تكون reactive. فكر في المريض انه بعد سنه وسنتين ممكن يحتاج فستله. حاجه ثانيه الفستله مش مجرد انفكشن، حتى اللو فلو لما يكونكت وعندك بيس ميكر مرات يقول لك والله ما يمشيش الدم، ما بعرفش مره صارت المريض هاد لو فلو، فهذه مشكله. اللي بيطلب منك النفراج يقول لك تحول البيس ميكر فقط بشيء ثاني. It's not just an infection, also avoid it because of the low flow condition. We try to be reactive. لما تعرف ان المريض possibly dialysis patient, try to be reactive. طبعا للاسف المايكرو مش موجود في الوقت الحالي، بس it's a great option. المايكرو بيس ميكر مفيش اي no needs.
Another thing you can probably help me with this. Sometimes patient has a cardiomyopathy from 100% RV pacing, and then fluoroscopy shows that the RV lead is basal and free wall. I mean, in those patients, I feel probably re-implanting or revising the lead septal before adding more hardware.
Basic, though, it's a great option. Easy.
Next question.
Assalamu alaikum. We have a lot of young patients with COVID-19 DCL rejection factor is between 20 and 25, and the patient don't go with medication. When we decide to refer the patient for CRT.
5% on medical therapy after threshold, and left bundle,
No,
no left bundle,
no problem.
no left bundle.
Yes.
I mean, there's no indication, مفيش أي indication. ICD only, ICD for primary prevention.
If the patient not responding to medication, that's why we put it. Or medication to repair to CRT, if not responding, then the patient start suffering.
Yeah. Before left bundle, or if you have right bundle with a QRS more than 170, also could be an indication for CRT. Because a right bundle should not cause the QRS to go above 140. So if you have right bundle 180 millisecond QRS, that's an indication for diabetes.
This may be not relevant, but obviously you have always to remember young patient, consider how transplanting they have the option, that's an option. Then there is more data coming now. We actually all exploring this option of some new technology called dynamic pulse, but this is just not for this meeting. So there are options, but they are probably something in advanced center will not be widely available, sadly.
So please, the next question.
The idea of by pacing in left ventricle beats after the right, and you want to synchronize the right or left. Already your QRS normal, and by مش هيجي لك أي فرق. بالعكس أنت تحط by it's not physiological. It's not as physiological as the normal conduction. But in that case, only ICD.
Assalamu alaikum. Dr. Zimatar. Just when we are facing problem of late pacemaker or device infection, for example, after 5 years. And in our circumstances, when we need extraction, I think it's not possible. So from images that you show that PET scan showing infection in the lead there. So if the choice that we are doing here, we keep the old lead in the left side, for example, and we reinsert pacemaker on the other side. So what about the risk of reinfection by this way? And what we recommend in our circumstances, please?
The question is, the patient has a lead and you're going to leave it and put another lead in?
I have late device infection, for example, after 5 years.
Yes.
And I need to extract them, right? Really, in our circumstances, especially if let's talk
If
about.
you can't extract, you're
You
going to
cannot
have
extract.
chronic antibiotic therapy. The
So
patient's going to have to be on antibiotics.
I'm asking if we keep the lead, and the lead is the source of infection. How is the infection rate? If we recommend that, and we implant on the other side.
Why are you implanting if the lead is working? It's infected.
Effective device.
It's infected, but it still works.
But for how long we keep it? And if we keep the device-
If the patient, let's say the patient, it's a good question. Patient's pacer dependent.
Yes.
The lead functions electrically, right?
Device effect.
The infection is just, infection means there's someone living with the lead, something attached to it, but the lead is still functioning. The infection on the lead does not mean the lead.
No, I'm saying you have bad pocket infection for the device after 5 years from implant. So you cannot keep the device.
Okay, beautiful. So you're saying you have a problem with the pus in the pocket.
Yeah.
Okay, so you could change the generator.
Yeah.
Clean as much as possible from the lead, debride as much as possible, and then do chronic antibiotic therapy forever. And then put a new generator.
The same place.
Yes, no, new generator, but the leads are going to stay because you said you can't take them out, right?
Because from what you show from the PET scan, the infection the lead sometimes, right?
Yeah, but if you give chronic antibiotic therapy, you're going to suppress it.
So you are not recommending putting in the other side.
There's no need to put more hardware if the previous hardware is working.
Okay.
The presence of infection,
Even infected.
because we do have, we do extraction, but we have patients who are not a candidate for extraction.
Yes.
They're very high risk, or they don't want it. And then the ID specialist will just give chronic antibiotic therapy. I'll change the generator. I'll clean the pocket as much as possible. And, sometimes what you could do, you can I put the generator submuscular. Submuscular, there's more vascularization. more immune system. Sometimes we remove we put the new generator just like a subcutaneous ICD on the side. So you kind of you remove the pocket a little bit more away from the previous infected pocket.
Thanks all.
The last question, please, Dr. Amran.
Assalamu alaikum, Amran Mawdi. I missed the talk, but I had a very important question that we face here in Libya for the last few years, which is a complex post-implant. Most of the operators they tend to give antibiotics post-implant. Back in antibiotics post-implant, post-pacemakers, they give a week of oral antibiotics. They think that they minimize the risk of infection. Back in 2014-15, we were one of the centers that we enrolled patients for a multi-center randomized control trials for giving an antibiotics post-device implant, either pacemakers or high energy devices. And giving an antibiotics post-implant didn't show any benefit for minimizing the risk of post-implant infection. So I need your input about this, because one of the problems that I faced here over the last few years, I implanted few numbers. I had 2 infections, and 4 of them, they were related to personal hygiene. One patient went home, had a shower, he was infected a week after, and the question to me, why you didn't give the antibiotics? Because A, B, and C, they give antibiotics post-implant. So please, I need your input on this. Thank you.
Antibiotic post-implant, does anyone here give more than 2 days? Yeah, so, I mean, I know some places will do 1 day, some places will do 2. I never heard more than that. The randomized control trial that I showed only proved benefit of IV antibiotic before skin incision. So 60 minutes for the ANSAP and 1 to 2 hours for the vancomycin. There's no randomized control trial to prove that post-PO antibiotic is beneficial, but we do give a day or 2. I don't think it's wrong if you want to give more than 2 days for someone who's on steroid, someone who's immune compromised, chemotherapy. I think it's okay to go up to 5 days, but that's rare.
Okay, just one comment that we implant our pacemakers in the cath lab, and usually the hygiene situation in our cath labs is not as to the standard. So maybe most of you implant your pacemakers in the theater, like in some countries. But we implant it in the cath lab.
Yes.
100 people, people, they are walking in and out of the cath lab. So that's why I think this is one of the issues about the infection control and sterilization points to be covered.
Yeah, that's an excellent point. We showed there has to be ventilation, positive pressure,
Yes.
air filter,
Exactly, which is not the case. It's not the case.
Something important also, like Dr. Khalid was showing that X-ray with a single chamber A. I mean, a lot of patients who have 6 sinus syndrome do not need a dual chamber pacemaker. I mean, more than half of what I implant in 6 sinus is single chamber A. That's all you need.
Just a comment. You're right, Osama. So in Toronto, there's almost 6 or 7 implant sites. Only one site they implant in the OR. And the main reason, because they don't have too much labs to cover the implant. So they have a daily implant. They implant daily, so they have a room in the operating or in the theater. But the other hospitals, we implant in the cath lab. And we have 5 or 6 cath labs, so we can switch between 2 or 3. So I know your concern, but we implant in cath labs. I implanted in cath labs, and the risk of infection there is almost 0.51%, and which is similar to the numbers in Libya. I mean, we did almost 150 to 100 over the last 5 years. We had 2 infections.
Okay. Thank you for the nice presentation, nice talks, nice discussion. I thank the speakers, all of you, for your presence here on the stage and for your nice information. And I will ask the attendees إذا كان في حد من الجماعة المسجلين إنه ياخذ شهادات الحضور والله من الديسك بتاع الجمعية. و thank you very